Bismillahirrahmanirrahim. So this is a involuntary contraction. So this is known as the urge. Okay. So this is a daily bladder diary. Let's come to the etiologies, the diagnosis and the management of these types of urinary incontinence, like in the stress. So the etiologies are the increase the urethral mobility. Okay, or the POP mean the pelvic organ prolapse or intrinsic sphincter dysfunction. Okay, where the pelvic diaphragm weak or change of the uretrovesical angle. Mean change in uretrovesical angle you can check by the Q-tip test. Okay, so where the angle is changed more than the 30-degree. And the main diagnosis is the Kafel test or the stress test. Okay, where the urine leakage. Okay, so always remember, so if there is stress urinary incontinence, so there is maybe pelvic organ prolapse, because it's commonly associated with the pelvic organ prolapse. Okay, so these are the different prolapse. Here you can see bladder is prolapsed here. Okay, and here what you can see here is a rectum is prolapsed. So here is the enterocoel, mean the small intestine has been prolapsed. So these are different organ prolapse, so which may cause the urinary incontinence, stress urinary incontinence. Okay, and Q-tip test. What is Q-tip test? So we put this tip into the bladder. So okay, and upon the stress, so it should be less than 30 in the normal. If it's the change in angle is more than 30, mean there is weakness in the pelvic floor. So that's why, which cannot support the urethra or the bladder. So that's why they at the neck of the bladder. So this tip change the angle more than 30, which is positive Q-tip test, which represent the stress urinary incontinence. Okay. So the next is the if it's a come positive, then you go for the Boney's test. Boney's test is what you support the bladder neck by 2 finger and check the urination. Okay, so upon the stress, if it's the urinate, so mean there is a descent of the bladder neck, or you can say the prolapse of the pelvic organ. Okay, and if it's the Q-tip test is negative, then you go for the Yusuf test. If it's come positive, so then mean there is a kinking of urethra or the urethral dysfunction. Okay, so in the Yusuf test, you actually give support by the forceps to the cervix. So if upon the stress, so if the patient urinate or a urine leakage, so this is the main positive Yusuf test, which represent this sphincter dysfunction. Okay. So what is the treatment option? Although it's a complex, so we usually start with the Kegel exercises. We strengthen the pelvic floor. Okay, replacement therapy, which delays actually the venous flexion, so which help to elevation of the neck. Okay, so and the urethroplexic means you have to repair the urethra dysfunction. Okay, this is summary of the different procedure. Okay, so TVT, where you give the tape through the vagina and attach with the abdomen. Okay, and the TOT, where you enter from the vagina and attach with the tape with the trans obturator. Okay, and here is the Kalpos suspension. Okay, where you attach the vaginal wall to the Cooper's ligament. Okay, so Cooper's ligament and the vaginal wall, and in the intraurethral injection. Okay, so you put the bulking agent here. This is the vaginal pessary. So we have discussed this management of the stress urinary incontinence. So this was somehow the tricky, other is the simple. Come to the etiologies of the urge incontinence. So it is due to idiopathic or older age, where there is a neurological detrusor hyperreflection, meaning it's continuously contracting. Okay, and there is decreased urge to wide volume. What is the normal the volume for the urge? 150, the first desire, and for the strong desire it should be 400. But in this case, the urge volume is less than this 150 or less than 400. Okay, so that's why it's start the urine leakage, and the residual volume is normal. Okay, and there is involuntary bladder contraction plus the leakage. Okay, in the treatment, of course, because it's associated with the autonomic, so especially which the cholinergic which cause the contraction, so give the anticholinergic, and the NSAID also prevent the bladder contraction. Okay. So what is treatment for the mixed? So always you should treat the urge because it's a medical, and then you treat the stress which is mostly the surgical. Okay. So first you have to treat the urge incontinence. Okay. For the total incontinence, how you can diagnose by giving the intravenous pyelogram with contrast. So check the X-ray where you see the leakage, or you can give the IV indigo caramine dye injection. So you will also see the there is a leakage in the fistula, or you will see the diverticulum. And urethrooscopy for better for the diverticulum. Okay. And the treatment, of course, the treatment is surgical. You should repair the fistula or the diverticulum. Here you can see the vesicovaginal fistula. Here is the urinary bladder. Here is the uterus, and here is the vagina. So there is the fistula. Okay. So here you can see the fistula between the uterovesical. Okay. And here is the vesicovaginal, and here is the urethrovaginal fistula. So these are different the fistula which can cause the urination, total incontinence, where the patient is continuously complain of the urine leakage. So here is the pyelogram where you can see the urethrocoel. Okay, and in this picture you can see the bladder diverticula. Now come to the urethral blockage. Why is the urethral blockage? Due to the bladder aporeflexia, or medication, or there is obstruction, or neuropathy like diabetes mellitus, or the stroke, which can cause the urethral blockage. Okay. So there is that's why we see the abnormal neurological examination in this condition. Okay. So what you see the residual volume is greater than the normal. What is the normal? It's a 50-100. What is in this condition? The residual volume will be higher than the 50 ml, and the bladder capacity reaches more than the 1000. Okay, and you will see the abnormal neurological examination where you do not see the detrusor contraction. So this is outflow. This urine leakage is not due to the contraction. This is due to overflow. Okay. So what is treatment? Treatment is a cholinergic which contract the detrusor and complete the micturition. Okay. And the alpha blocker. Alpha blocker do what? They relax the internal sphincter, so there is complete micturition. So they, in this way this problem is solved. Okay. How can we check the different volume of the bladder? By cystometry, where you put a catheter and you check the initially you check the residual volume. Okay. So then so this is the normal cystometrogram where you see the early there a first sensation of filling, so volume is increasing, and when it reaches near about the 400 to 500, so there is the strong desire, so you void and then the hold and then void. So this is periodical the micturition. Okay. How can we check the bladder capacity? By adding the fluid. Okay, and ask the patient when she feel their bladder is full, and when she feel the desire to micturate. So we note those volume and compare with the normal one. Okay. So these are the normal graph, and this is a normal abnormal where the detrusor overactivity. Okay. So mean that this is the urge condition. Okay. So there is a low compliance condition. Filling is stopped. So come to the last segment, that is irritated etiology. You know better, infection, the stone, foreign body, the bladder tumor. What is the diagnostic? Diagnostic is a suprapubic tenderness. So it's suggested for the irritation. Okay, and you do the urinary analysis where you check the WBC and RBC. If you see the WBC and RBC in the urine, so if there is an increase in the WBC, means it's suggested for infection. You can confirm by doing the culture. If the culture is positive, mean their condition is the infection. You give the antibiotic for the treatment. If there is increase in RBC, mean the red blood cell are increased, so there is risk of the foreign body, or there is a tumor. So you do the cystoscopy. What is cystoscopy? this is the cystoscopy where you see the internal picture of the bladder. Okay, so here you can see the stone. After the confirmation of diagnosis, you should treat the underlying condition. Okay, this is the all about the urinary incontinence. Here is the summary chart what we have discussed. Okay, thank you very much. Allah Hafiz.